Ladies and gentlemen, dear colleagues, it's really a pleasure to be here today with you to share our experience with aortic valve repair. So first I would like to thank the organizing committee for the invitation, and especially Dr. Banovic and Dr. Putnik. I met Dr. Putnik more than 15 years ago in a fantastic fellowship in Leiden in the department of Professor Dion. And when I come back to Brussels, I start working in the Clinique Universitaire Saint-Luc, where I'm still working under the leadership of Professor Gebrin El-Khoury, who was already running when I came back the program of aortic valve repair. And it is especially his development that I will present you today and that I had the chance to learn now since the year 2008. So aortic valve repair is dedicated to young patients who are suffering from aortic regurgitation and aortic root aneurysm. So we are leaving the area of aortic stenosis in old patient, inoperable patient. Why should we propose them aortic repair? Is to avoid for them the replacement with a mechanical valve or a biological valve and the burden of the complication related to those prostheses, lifelong anticoagulation, thrombosis, bleeding, excess mortality, and endocarditis linked with the mechanical valve, and eventually degeneration, reoperation, and endocarditis linked with the biological valve, especially in the young population. Now, repairs performed since more than 20 years now in those patients, and it has proven that it does not need anticoagulation. There is rare valve-related complication with this technique. There is low reoperation rate, a better quality of life, and eventually a better survival. Now, for sure, TAVI will come for aortic regurgitation, but the dedicated device for regurgitation are not ready yet for regular use, clinical use, and still aortic valve repair has good years in front of him for this young class of population. Aortic valve repair is now recommended in the guidelines for AI and for patients with aortic root aneurysm. So what is the goal of aortic valve repair? The goal is, like in mitral repair, is to restore and preserve the cusp geometry and motion, remodel and stabilize the annulus somehow, to create an optimal area of coaptation which is stable for a long time. Now, a bit of surgical aortic valve anatomy, which is important when you intend to repair the valve. It's good to know that the cusp size, which is can be translated as the geometric height, is about 90 to 20 millimeter in the patient that you will usually repair. And a decrease in this geometric height may be a contraindication for the repair. And the number of 15 millimeter has been advocated by some specialists. Also, the free margin of a normal aortic valve is about 33 to 35 millimeter, and this may be elongated in many circumstances of aortic regurgitation or root aneurysm, and you will have to deal with this elongated free margin. Now, the general aspect of the aortic valve into the aortic root is also very important, and this is a configuration that you will have to restore when you repair an aortic valve. And the concept of effective height, which has been introduced by Jochen Schäfers, is very important, and the 9 millimeter of effective height is very important when you treat your valve. This is what normal aortic valve look like into an aortic root, and there is dedicated intraoperative device that can help you to reach this normal configuration when you are repairing a valve. Now, to repair a valve, you need to understand the mechanism that leads to the regurgitation, and you have to treat those lesions. And we know that from the mitral valve, since more than 30 years, a classification helps you to understand those mechanisms and to orient your repair. And in the mitral valve, you know that when you repair it, you do a leaflet job, when you resect a P2 prolapse, for example, and then you place an annuloplasty for adapting the size of the annulus to the leaflet size to create a stable coaptation. Now, for aortic valve repair, we need similar work to develop a good strategy to repair. And that's what Professor El Khoury made during the early time where he developed the aortic valve repair program. He made this classification of aortic insufficiency and dilatation to help and orient the technique of aortic valve repair. So this classification is divided in 3 main types of aortic regurgitation. The type 1 is related to the dilatation of the aorta. The type 2 is related to the cusp prolapse, and the type 3 is related to the cusp restricted motion or cusp retraction. Now, the type 1 is subdivided in 3 different categories depending on the localization of the aneurysm. The most easiest repair is a type 1A dilatation of the ascending aorta. You have a large sinotubular junction. You have a leaflet tethering because of its dilatation, and remodeling of the sinotubular junction with the supracoronary ascending aorta replacement has proved to correct this regurgitation, and eventually you can add subcommissural annuloplasty stitch, Cabral stitch, to get rid of residual regurgitation. Now, a more challenging regurgitation to treat is when it's linked to the aortic root dilatation, where you have also this cusp tethering, you have artificially increased effective height because of the enlargement of the sinotubular junction of the root. And the technique to repair that is the remodeling technique and the reimplantation. As you know, the remodeling technique can be performed with or without an annuloplasty, whereas the reimplantation provides, in any case, this annuloplasty. That's why it has been advocated probably in patients with connective tissue diseases, in patients with aortic dissection, and following us, it is the most versatile technique which can be used in any case where aortic root is dilated in any valve configuration or any kind of patient. So this is the technique we use on a routine basis with the Valsalva graft. As I said, there is a diastolic restriction with central AI generally. Effective height is supranormal, and there is most of the time, because of the chronic stress on the leaflet, an elongation of this free margin and of the geometric height. So for this reason, when you make a valve sparing reimplantation, you have to check the leaflet configuration at the end, because you reduce the size of the root and you may create a prolapse by reducing the sinotubular junction and the size of the root, and by controlling the effective height you may correct this configuration of the cusp inside the new aortic root and get rid of this prolapse that would lead to early recurrence of aortic regurgitation. So I have here an example of a young patient with a bicuspid valve with aortic regurgitation and moderate root dilatation. The annulus is 3 centimeter, the root is almost 45 millimeter, and the bicuspid valve has a commissure orientation of 160 degrees, which are the most favorable orientation to repair, because the valve is already almost symmetric. Is it running now? So this video is probably a bit long, but okay, it's running there. You see this bicuspid valve with the huge prolapses of the fused cusp. So we make routine measure of this cusp. I cannot go forward in the movie. Anyway, so we start the root dissection by removing the sinus, and then we will cannulate the coronary ostia with the cardioplegia cannula and give the blood cardioplegia every 15 minutes, and we can continue the dissection quite deep to reach the basal ring, which is the plane passing through the nadir of the cusp. And this will be our target for placing the proximal suture line of the David procedure. Here we are dissecting between the muscle of the right ventricular outflow tract and the interventricular septum muscle, where you can generally find a plane of dissection. Here we are at the level of the roof of the right atrium and the RVOT. There was some kind of rupture of the free margin at the commissure, so we make some atypical plication at the commissure there to get rid of this severe prolapse. And the stitch was reinforced with some pledge of aortic wall piece. By doing that, the prolapse was completely or almost completely corrected, and we resect the residual raphe to improve the mobility of the cusp. This is the proximal suture line. With pledgeted U-stitch, and they are placed on the anterior circumference. And by doing that, we will be able to constrict a little bit more the side of the fused cusp that took more of the circumference of the annulus. So by constricting there more than on the opposite cusp, we will make the valve completely symmetric at the end, with the reimplantation of the commissure at exactly 180 degrees. By doing that, we will transform this type 1 following Siever's classification bicuspid valve in a type 0 with a symmetric opening and those are probably the more favorable configuration for those bicuspid valve. As we know from experience, type 0 valve have a better function than the type 1, and probably the repair transforming a type 1 in type 0 would also improve the long-term durability of the repair. At least there are some signal of that in the literature with those symmetrized valve having lower gradient, less need of patch for repair, and probably better repair durability, as already shown in one of two papers. This is the secondary suture line for attaching the remnant of the aortic root to the prosthesis wall. The commissure have been reimplanted at 180 degrees, as you can see. And here we adjust the level of the free margin of the two cusps inside the neo-aortic root by measuring the effective height and eventually adding some central plication to the cusp to have this 9 mm of effective height at the end. And this is the final result. Here on the echo, you see the aspect of the repair, no regurgitation, and a good valve opening with especially a good effective height. Also can be measured at the echo, and a commissural orientation that move from 160 to 180 degree. So this capacity with the valve sparing operation to change the geometry of the valve is especially interesting in the very asymmetric bicuspid valve, where the use was to repair those valves with a pericardial patch. But you know that pericardial patch, when you repair, is always a risk factor for early failure. So to avoid this pericardial patch, you can make the valve symmetric, and it gives you more tissue to close the unfused portion of the raphe by doing this asymmetric annuloplasty and making the valve symmetric with an orientation of 180 degrees. Then you have annulus dilatation, that it's called 1C in our classification. Dilatation of the annulus is very frequently associated with cusp prolapse because it dramatically reduces the effective height of the coaptation. And there are several ways to reduce the annulus. One is the Cabral stitch, another is the reimplantation technique, and then there have been circumferential annuloplasty developed by colleagues, like the Coronero ring, external aortic ring, developed by Emmanuel Lansac, or the suture annuloplasty developed by Jochen Schäfers, and finally the internal 3D geometric ring developed by Scott Rankin. In our experience, we use especially those three types of annuloplasty to repair annulus dilatation, and this is our algorithm to use those annuloplasty when we treat patients with AI. So roughly when the root is dilated, we use the reimplantation technique. When the root is not dilated, the annulus is not dilated, we still use the Cabral stitch. It is a very convenient and rapid technique to increase the coaptation when you do a repair. You can use it in old patients, endocarditis, and especially when you have a small annulus, but also small leaflet, you equilibrate the size of the annulus and the leaflet by using this. Then we use the external ring technique whenever the root is normal, but the annulus is very enlarged. And when we want to modify the bicuspid valve geometry, we use the reimplantation technique. Now, we have also cusp perforation, is the type 1D in our classification. In some endocarditis, in very normal valve, you may have just one perforation on a leaflet. Before to throw this valve to the garbage, think about just cleaning the hole in the leaflet and put a small pericardial patch. In our experience, those repair with a patch on the normal tricuspid valve can last for more than 10 years without a problem. Finally, you have the cusp prolapse. Cusp prolapse is characterized by some billowing of the cusp and eccentric regurgitation. Prolapsus is typically treated by central plication of the cusp in tricuspid as in bicuspid valve, and the effective height is controlled with the caliper. This is an example of a left coronary cusp prolapse associated with annulus dilatation. You see that the annulus should be at least 28 millimeter, and you have an eccentric regurgitant jet coming from a prolapse of the left coronary cusp, which is obviously lower than the two others. So because the root is normal, we will not replace the root in this case. We don't want to change the geometry of the valve. So we dissect the root at the level of the basal ring while preserving the aortic sinus and the coronary attachment, and we will perform an extra aortic circumferential ring annuloplasty. For that, we use not the Dacron piece or the coronary ring, which is well to use with the remodeling technique. We use the Simplicity band, which is a band dedicated that has been developed for tricuspid or mitral valve repair. This band is attached with a U-stitch placed all around the circumference. The band is placed below the coronary ostia, and once the annuloplasty is performed, we take care of the prolapse by doing central plication. You can do your central plication by comparing the leaflet free margin length from the normal ones to the prolabing one, and you remove the excess of length of the prolabing one for the correction. And this is the final result of the repair. Finally, type 3 is not the best indication for repair. You have typically a cusp retraction, and those valves may be in some cases better replaced than repaired. But if you want to push the limits of the repair, the technique that you should use for a patient with cusp restriction and AI is cusp extension using pericardial patch, but you know that this material is prone to degenerate with time, and it is essentially indication that you will have in a very young patient in whom you want to avoid valve replacement with in patient still in the growing period of age. Now, these are the different type of cusp extension you can make on those patients. A cusp extension at the base, commissural reconstruction, sometimes only with shaving, or in bicuspid valve, in modifying the geometry of the valve, you can get rid of a pericardial patch. Otherwise, it is a repair with patch. Now, the different mechanisms of AI are often associated when you will treat a patient, and this is a patient that we have treated last year during one of our meetings. It is a tricuspid regurgitation because of right coronary cusp prolapse. In a dilated aortic root, we had to repair the commissural fenestration rupture with a pericardial patch and with a David technique, and you have the final result. So you have to integrate all those mechanisms of regurgitation. You have to know them. When you start an aortic valve repair program, you need to know about the anatomy of the aortic valve and those different mechanisms leading to AI, and you have to master the technique of repair. Of course, it's more stitch and more complex than to put a TAVI, but I believe that still in young patients with long life expectancy, this technique can provide excellent results, and the big center that have developed aortic valve repair program and the different technique to standardize aortic valve repair could show more than 90% freedom from reoperation over 10 and for some 15 years. So I believe this is still a very good technique that you can apply in young patients with AI and eventually root dilatation. Thank you for your attention, and if you want to learn more about those techniques and the technique of the other team, I warmly welcome you in Brussels in June, where we have the 5th Aortic Valve Repair Summit, where we have 2 days dedicated to aortic valve repair and the different technique to do that. Thank you very much.
Thank you very much for this really sophisticated lecture and impressive demonstration. I am excited like a student to see. I would like to be a surgeon in my next life. Although I don't know whether they're going to be surgeons in my next life or interventional cardiologists, probability-wise. Yeah. So are there any comments from the surgeons, basically, or any questions? I'm speechless, must say. Oh, please, yes. Okay, please.
I'm pediatric cardiac surgeon from Serbia, and I would like to ask you, do you have any idea or any thoughts regarding the Zakis procedure? And do you have any experience on hospital with those patients, especially in pediatric surgery patients?
No, we don't have experience with Ozaki because I think it's not a bad option. I mean, but at the time you replace the 3 leaflet with pericardium, at least in the adult, just replace the valve with a good bioprosthesis. And I know a couple of centers who start this program, and after 2-3 years they have abandoned, at least in the adult. It's just because, yeah, pericardium is just something you cannot predict the outcome. Now, Ozaki procedure is a good procedure. I think it's reconstruct a nice aortic valve, well functioning, and most probably it lasts for years. But this will not be the case in all your patients. Then you have still endocarditis on those valves, and then for the pediatric population, in our center we try to repair those valves by implanting at least as possible of pericardium patch.
So you wouldn't even do a cusp extension of the pericardium?
Sometimes we do cusp extension, but we try to use as few as possible of pericardium. And then we still use the Ross operation for pediatric patient when we think the valve is not repairable, and we are not choosing to do the Ozaki. It can be an option. I mean, if you want to delay a little bit or more the Ross or the aortic valve replacement, it can be an option.
Okay, and one practical question. When you're doing external annuloplasty, do you tend to undersize, or how do you determine the size of the simplicity band?
So when you do an annuloplasty, it's because you want to reduce an annulus of of 30, which is clearly enlarged, which is most of the case in all bicuspid valve with regurgitation. You have an annulus about 30 or 29 or even more. In tricuspid valve, large annulus is a bit more rare, but when you have regurgitation, annulus is generally about 28 at least. And you want to bring it back to a normal size, which is about 23, 24, eventually 25 in a big patient. So there are different type of calibration technique. With the coroneo ring, you can have different size of ring. With open band or with suture annuloplasty, you can just calibrate on a Hagar dilator, which is 23 or 24, 25 eventually, depending on the size of the patient and also on the size of the leaflet. If you have small leaflet, you will choose for a smaller Hagar dilator to adjust the size of the leaflet to the orifice of the valve you want to leave. Just to say a word on the surgeons of the future, I think they will be needed to treat patient with endocarditis and patient with TAVI with endocarditis and with patient with TAVI in TAVI in TAVI to probably put them nice bioprosthesis. And regarding aortic valve regurgitation, you have to know that most of the regurgitation are present in association with a certain degree of root disease. And TAVI will not treat this root disease. Most of aortic regurgitation is present in a root which has 40 or more than 40 millimeter in diameter. And it's young patients, so maybe you can treat the regurgitation with the TAVI. But what about the durability of this bioprosthesis in a young patient? And then what about the root pathology that will not be treated? And what about coronary disease with the one TAVI and a second TAVI for angiography, catheterization? And so I have good hope that surgeons will have a lot of work in the future. Thank you.
So we shall have in interventional cardiology more robotic procedures. Yeah. I think that actually robotic procedures will be perfect for the TAVI, even more than for the coronary intervention. I have done a few robotic PCI, but for TAVI it will be quite easy, I suppose. Okay, thank you very much. And now, as we have really condensed program, and we are now moving to the last presentation of this session, or aortic stenosis in children.